Okay. Welcome to this online meeting in India and Holland. In this meeting, we see Prafulla, of course, the candidate, her supervisors, Professor Gidi Hari and Professor Onno van Schaik, the degree committee, the beadle, and I'm the pro-reg today. And in the background, we have the technical support team, but we hope we don't need them, that all things will go right. So, hereby I open this academic ceremony in which Prafulla Shriyan will defend the academic thesis, Psychosocial Environment during the perinatal period and its adverse impact on mother and child health. Prafulla, may I invite you to present a summary of your thesis and the conclusions of your thesis?
Thank you, dear poet. Dear Prorector, members of the Corona, my dear colleagues, family and friends, thank you for joining me today to discuss on my PhD research on psychosocial environment during the perinatal period and its adverse impact on mother and child health. Imagine the stress and the excitement of becoming a new mother. For many women, lacking support and resources may experience this even more harder. In the next 15 minutes, I'll be talking about how the psychosocial environment, especially the depressive symptom during pregnancy and the postpartum, and the support she obtained during pregnancy and the postpartum, how it affects on the mother and the child health. Perinatal depression is a global health issue which disproportionately affects the women in low and middle income countries, where 1 in every 3 pregnant women and 1 in every 3 postnatal women in LMICs were experiencing depressive symptoms. In India, 1 in every 4 pregnant women and 1 in every 3 postnatal women are experiencing the depressive symptoms. Mental health disorder pose a significant burden in India, accounting for 14.5 years of life lived with disability. Despite this, mental health screening remains inadequate across many settings. There's a clear research gap in low and middle income countries, including India, especially among vulnerable population. The existing studies have methodological limitations, such as underutilization of biomarkers, which hinder our understanding long-term impact of perinatal mental health. Hence, prospective studies are important to address this gap and provide evidence and to support development of effective intervention. My PhD research was built upon the foundation which was led by Maastricht birth cohort study, where Maastricht had set up 2 research objectives, where the primary objective was to investigate the effect of blood glucose level in pregnancy on infant adiposity, whereas the secondary objective was to investigate the effect of psychosocial environment of mother on adverse infant outcomes. My PhD research was contributed exclusively for the secondary research objective. Here in Maastricht, we started our enrollment in the year 2016, and by the year 2019, we were able to recruit around 3,000 pregnant women and followed both the mothers and children. The aim of my PhD is to investigate the effect of perinatal depressive symptoms on both mother and child health. Here, this framework represents the flow of studies I have been conducted in my PhD journey. Initially, to start with, I examined how the depressive symptom during pregnancy influence the gestational blood glucose level through chapter 2. Later, I investigated the serum cortisol and how its effects on postpartum depressive symptoms through chapter 5. I also investigated depressive symptoms during pregnancy, stress biomarker cortisol, and its effect on adverse birth outcomes, including small for gestational age, low birth weight, and low weight for length through Chapter 4 and Chapter 5. Further, I also looked into the long-term impact of postpartum depressive symptoms on adiposity and stunting through Chapter 6. Lastly, I investigated depressive symptoms during pregnancy and postpartum and its effect on delay in achieving developmental milestones. Here in Chapter 2, I looked into how the maternal psychosocial factors influence blood glucose level. The specific research question is there a significant association between maternal psychosocial factors and gestational blood glucose level? Here, the depressive symptoms assessed during pregnancy and the social support she obtained during the pregnancy was exposure, and the gestational blood glucose level, which was assessed using 2-hour oral glucose tolerance test, was the outcome. The biological mechanism behind this association is whenever the pregnant women experience excessive depressive symptoms, it leads to an increase in stress hormone secretion. This impact by increasing the insulin resistance, thereby influencing the increased blood glucose level during pregnancy. Here, the area graph shows there is increasing trend in correlation coefficients for both fasting and postprandial blood sugar against the increasing cutoff scores for the depressive symptoms. In the results, I found that pregnant women with higher depressive symptoms and poor social support were more likely to have higher blood glucose level, both fasting and the postprandial. In Chapter 5, I looked into how serum cortisol impact postpartum depressive symptoms and fetal growth. The specific research question is there a relationship between serum cortisol level during pregnancy and postpartum depressive symptoms? Here, the serum cortisol level, which was assessed during pregnancy using early morning samples in the subsample of cohort participants, was exposure, and the postpartum depressive symptoms, which was assessed after the delivery, was the outcome. The biological mechanism behind this association is whenever there is increase in serum cortisol in response to excessive experience of depressive symptoms, so the level of serum cortisol increases in the blood. But when immediately after the delivery, the sudden drop of serum cortisol level leads to dysregulation of hypothalamic pituitary adrenal axis. This in turn led to postpartum depressive symptoms. In the results, I found that women who had higher cortisol level in the pregnancy had 2-fold higher odds of having postpartum depressive symptoms in comparison to those women with a lower cortisol level. The second research question, Chapter 5 is explored is there a relationship between serum cortisol level during pregnancy and infant birth outcomes? Here, the serum cortisol level, which was assessed during pregnancy using early morning samples, was exposure, and the newborns with low birth weight and low weight for length were the outcomes. The biological mechanism behind this association is whenever the pregnant women experience excessive depressive symptoms, it increases the secretion of serum cortisol. This in turn led to uterine artery resistance index, which restricts the flow of blood to the fetus, thereby impacting the growth of the fetus. In the results, I found that pregnant women with higher blood cortisol levels had 2-fold higher odds of delivering a baby with low birth weight and low weight for length, in comparison to those pregnant women with having lower cortisol level. In Chapter 6, I explored how the maternal depressiveness, also called as postpartum depressive symptoms, impact infant growth, which was assessed at their first birthday. The specific research question is there a relationship between postpartum depressive symptoms and infant obesity and stunting at 1 year of age? Here, the depressive symptoms which was assessed at the time of the delivery was exposure and the infant anthropometric markers for the adiposity and stunting, which was assessed at the age of 1 year, were the outcomes. The biological mechanism behind this association is perinatal depressive symptoms impact the child growth through hormonal and biological mechanism. So coming to the hormonal mechanism, whenever pregnant women experience excessive depressive symptoms, which alters the intrauterine growth, this impact by decreasing the body size and increasing the central distribution of fat, thereby causing adiposity and stunting. So coming to the behavioral pathway, where women who had higher depressive symptoms may find it difficult to provide responsive caregiving. This may impact her feeding practices. They may start initiating the formula feeding earlier than the recommended period, thereby impacting the growth patterns. Here, my results are quite alarming. I found that women who had higher depressive symptoms after the delivery had threefold higher odds of having children with a greater waist circumference and sum of skin fold thickness in comparison to those women who had lower depressive symptoms. Additionally, I also found that women who had higher depressive symptoms after delivery had 1.7 times higher odds of having children with stunting. In Chapter 7, I looked into how these perinatal depressive symptoms hinder the developmental milestones of the child. The specific research question is there an association between maternal depressive symptoms, which was assessed during the perinatal period, and the global developmental delay during pregnancy? Here, the both depressive symptoms which was assessed during pregnancy and the postpartum were the exposures, and the global developmental delay, which was assessed at the time of 14 weeks and 1 year, were the outcome. We have used Trivandrum developmental screening chart to assess the child's ability to achieve developmental milestones in areas such as gross motor, fine motor, language, and social domains. The biological mechanism behind this association is the perinatal depressive symptoms alter both intrauterine environment and mother-child interaction. This, in turn, affect the impaired brain development and reduce growth will hamper. So this may impact in terms of child's ability to achieve the developmental milestones which is supposed to be achieved at their expected age. In results, I found that the women who were having higher depressive symptoms during pregnancy had higher odds of having children with global developmental delay, both at 14 weeks and 1 year. Here, the findings for postpartum depressive symptoms are also similar, but however, the magnitude of association for pregnancy is higher in comparison to postpartum. To summarize, in Maastricht birth cohort, I found 1 in every 10 pregnant women and 1 in every 3 postnatal women experiencing depressive symptoms. I also found that depressive symptoms, elevated cortisol, are linked to the higher blood glucose level during pregnancy and increased risk of postpartum depressive symptoms. My study also showed that there is a link between perinatal depressive symptoms and adverse infant outcomes, including poor growth outcomes among newborn, obesity and stunting, and global developmental delay risk among young children. It is a time to take action to enhance the perinatal mental health and to have a better health outcome of the child. So in order to address this, we need to implement comprehensive screening, and focus has to be given to integrate the screening with the routine antenatal care services. And there is also need to train healthcare providers in screening aspect and assessing the severity of the depression and treatment aspect of the perinatal mental health. Greater investment in research is also required in India. So in order to explore mechanisms that are linking perinatal depressive symptoms on adverse birth outcome and child development, identifying and exploring more precise biomarkers is important in order to confirm the association. Further research is also required to investigate the role of mother-child interaction and the child feeding practices and their contribution towards causing global developmental delay and child adiposity and stunting. Lastly, so it's also important to identify the barriers and enablers for accessing mental health care, and addressing the barriers is very much important. So as we observed, pregnant women who are very reluctant to go near psychiatrist, as they are more worried about so what others may think and their concern towards their privacy. So because majority of the time they were accompanied by their in-laws and partners. So with this, taking all the steps, we can make a significant contribution towards maternal mental health, and it can lead to better health outcomes across society in India. With this, I'll end my presentation and giving back the floor to the director. Thank you.
Thank you for your presentation. The opposition will be opened by Professor Geert-Jan Dinant. He's the chair of the assessment committee, and he's a professor in general practice at Maastricht University. The word is...
Okay, thank you, Pro-Rector. Dear candidate, can you hear me?
Yes.
Okay, excellent. Well, first of all, my congratulations for a very nice piece of work, very thorough piece of work as well, and on a very relevant subject. That you also managed to publish quite nicely. And thanks again, also thanks for a nice presentation that you just gave to us. Now, I prepared a few questions. Don't get nervous, because they will be easy to answer. And the first question is just a very short one. It regards the title of your thesis. May I ask you to loudly read the title of your thesis again?
Psychosocial environment during the perinatal period and its adverse impact on mother and child health.
Okay, thank you very much. Now, I was wondering about the word adverse. Why don't you say just impact instead of adverse impact?
Okay, thank you, dear opponents. Thank you for your questions. So I chose adverse because while exploring the effect of psychosocial environment on the mother and child health, I think I found all the relevant findings related to negative consequences in mother and children. That is why in my opinion, I thought it is better to put it as adverse rather than impact, because impact we can only focus on the long-term outcome. Here, I also included the short-term outcomes with respect to mother. So preferably, I put it as an adverse impact.
Yeah, sure, I understand, of course. Now, I've been a medical doctor for quite a few years, and have seen many depressed patients who were pregnant, patients who had diabetes. And among those groups, quite a few were very happy, to be honest. So that brings me to the second question, and that's the relation between the three that I just mentioned. So let's call it psychosocial factors, or in fact depression, and then pregnancy, and then diabetes. You connect the three, which is, I think, a very clever thing to do. And you also, let's say, summarize the connection between the three, or the relation, as a so-called biomedical mechanism underlying, I would say, almost your complete thesis. And you conclude on page 171, but you don't need to look it up, that we need more research on this relation between the three. Now, may I ask you to, let's say, spend a few words on your, let's say, personal and experienced thoughts on this, let's say, further research and to, let's say, the relation between the three?
Thank you for your questions. So actually, In the chapter, I had looked into the biological mechanisms by assessing the cortisol level. So, where the depression during pregnancy will tend to have more higher level of cortisol, which can negatively impact the blood glucose level. So this has been noted in several other research also. So with this, I have attempted to clear the goal of my research objectives by assessing these are the certain factors which were certainly impacting on the mother and child health outcomes.
Okay, well, thank you. But does it mean, let's say, going back to clinical practice, does it mean that we should advise doctors to measure more frequently cortisol levels in our patients? Or would you say, well, that's maybe too soon?
Thank you for your question. It's a very good question. Actually, in the current status, we do not have any screening mechanisms in order to identify the women who have depressive symptoms during pregnancy or the postpartum. So my intention is this is the time to start the screening process and try to identify the women who are at least having severity with respect to severity of the symptoms. And then later, when it comes to the confirmatory diagnostic process, so one treating physician can suggest a diagnostic test in order to confirm the presence or absence of the stress level.
Yeah, okay. Well, thank you again. Now, maybe a final question, if I may, Pro-Rector, that regards to proposition 5 in your thesis. Maybe you can read it loudly to us.
Mm-hmm. Give me a bit feminist.
Yeah. Shall I read it to
Right.
you?
Yeah, I don't have the help.
Okay, I'll help you.
Yes.
I'll read it to you. So proposition 5 says fathers matter, double dot. Engaging fathers in early childhood development plays a crucial role in the child's growth and well-being. Now, making it, let's say, it's a bit more geographical, I traveled quite a lot also in neighboring countries to India, like Nepal and Sri Lanka. And not yet India, by the way. But anyway, I've seen many fathers and mothers walking around and living there. Quite interesting. Well, the same in our country, of course. And I was, let's say, intrigued by, after you made this proposition, on how exactly you think that fathers should be more engaged or involved in what you mentioned there.
Thank you, dear opponents. Thank you for your questions. In the current scenario, especially in India, I'm only particularly defining the status for the Indian setting, where majority of the time, pregnant women, so who comes to the facility along with her mother or a father or her in-laws. So they prefer only accompanying with the ladies. And in the health facility setting also, many of the in public health hospitals facilities, they don't encourage men to enter the facility because it may compromise the other privacy of the other pregnant women. Now this focus has to change now. So we have to include, encourage men also whenever they start whenever they come to the facility for the consultation and the diagnosis and the other things. So we need to include them as well and treat them and with the equal opportunity as well as for the ANC pregnant women we are giving.
Okay, thank you. The final question, does the issue that we're just addressing also regard other countries in the world? And if so, which countries in particular are you thinking of?
Could you please repeat the question, the opponents?
Yeah, but just shortly, I was wondering if the issue of fathers being more engaged
Yes.
regards just India or maybe also a few other countries? And which countries in particular would you say?
Thank you for your questions. I think I meant only for the India. I'm not very particularly sure about what other countries. They're also not encouraging men participation in the ANC and birth outcomes or birth facility deliveries.
Okay, so we can still continue the way we follow in our country, in our very small country, the Netherlands. Thank you so much for your answers. I'm very happy, and I'm happy to give the floor back to the prorector.
Thank you.
Thank you. The opposition will be continued by Professor Prashant. He was a member of the assessment committee and he's a director at the Institute of Public Health in Bangalore.
Thank you, Prorector, and I hope I'm audible to the candidate and to the others.
Yes.
Thank you to the candidate for an excellent presentation, and I join the Professor Dinon in complimenting you on being able to publish many of your findings in good journals. So that's always nice to see. I wanted to build a bit on the previous discussion on father's involvement, the proposition, one of the propositions that you make. I would like to hear your thoughts. I develop a point that I want to make on psychosocial. So multiple papers and chapters talk about the psychosocial component of maternity and on its impact on child development. For me, psychosocial is much beyond depression, much beyond what an individual experiences, in this case, the mother. So if I were to frame, I'm framing this a bit provocatively. I'm saying that you have largely examined an individual mother's depression and you're calling that psychosocial. I would like to hear your response to what other dimensions of the psychosocial environment of mothers have you actually examined in your thesis, or am I mistaken? For example, if I say that you have only looked at depression as psychosocial and psychosocial dimension is larger than that. Over to you.
Thank you, dear esteemed opponent. Thank you for your questions. Here, we in our Maastricht birth cohort, we looked into the Edinburgh postnatal depressive symptoms to assess the depressive symptoms, and the locally developed social support scale. It has been used to assess the social support that she has been obtained during pregnancy and after. So in order to say the EPDS tool not only capture the few items in terms of the anxiety symptoms related to depression, but beyond the depression, it also assesses the anxiety and the resilience level coping mechanism and the self-harm, and including the self-esteem also it captures. So these are the very prominent domains which also able to capture in the EPDS tool. With respect to the social support, here I want to mention here this particular tool is able to identify the social network she is access to, and there connects a relationship between the community, including the neighborhood and the family, and what are the supports or encouraging they have been getting from the family, including the neighborhoods. I think with this combining these two scales, so I think we are able to assess the broad dimensions of the factors which really contributing to the psychosocial environment.
Thank you for explaining how the measurement is beyond maternal depression alone. But I would like to develop this a little bit further. The proposition that you were discussing with Professor Dino had to do with father's participation. For me, this is an issue of gender and specifically on gender roles that we have. And we live in a world where gender expresses itself differently in not only in diverse geographies and countries, but also in individual families. There can be variations from one family to another. So when you come up with this proposition, I want to push you further. And can you share how empirically grounded is this proposition in your data when you say that fathers' participation is an important element in Indian settings? While I agree with you, based on my general kind of an assessment of how gender roles operate in Bangalore society, I want to understand a little bit more the empirical grounding of this in your study. Can you explain that, please?
Thank you, dear opponent. Thank you for your question. In Maastricht, actually, initially we thought of enrolling the father as well, including the pregnant women. But as we see, a lot of women were more familiar and comfortable with accompanying with their mother and in-laws, mother-in-law. So finally, we were unable to communicate with the fathers and their engagement with the pregnant women with respect to the care, what they should obtain, and what are the things to be taken care during pregnancy and the postpartum. So we were finally we were not able to achieve it. So my concern is this is the time so to encourage all the fathers to give an importance and accompany the women whenever they are accessing care to the delivery facility. So in order to, and the healthcare providers also need to encourage the men participation, include, especially in this maternal and child health services.
Sure, I understand that this was part of your context and part of your observations, but how much did you actually get opportunity to study it? How do we? I mean, do we have some assessments of fathers' participation, for example?
I think this is a very good question. Initially, we planned for assessing the psychosocial factors, including the anthropometric assessment among fathers, but having their involvement and with the accessing care to the facility along with the women, pregnant women along with their wife, I think we would find it very hard to engage with the fathers. So it was, I think, very hardly one. Almost out of 3,000, I think hardly one or two we were able to interact with.
That's all right. But this is indeed very understudied aspect of maternal mental health in India, I believe, or rather in terms of maternal health itself. So I feel that this aspect has been relatively less developed in your thesis, but I appreciate your response. Moving on to inequities. Now, if I understand correctly, this is 3,000 women who are from one cohort, the Maastricht birth cohort. How diverse was your cohort, and to what extent can we say that in a city like Bangalore, which is a very heterogeneous city, high levels of inequities, you have very rich households, you have very poor households, and several kinds of households in between. Can you help us understand what kind of households are better represented in your dissertation, and whether we should be careful before we look at the results? To what kind of contexts or settings or households would your results apply to, given that you have studied these 3,000 households? Thank you.
Yeah, thank you for this question. It is very interesting question. So we had complexity in inequality. We had assessed socioeconomic status, including gender, caste, and other regional disparities, but often intertwined with the socioeconomic factors, making it very challenging to disentangle their specific effects without more comprehensive data. So I think majority of the women who participated in our cohort belongs to the lower socioeconomic status. So while interpreting this data, I think has to be interpreted for the wider population, having the majority of the population who have participated in the cohort were lower socioeconomic status.
I would like to push back a bit. You say caste, gender, and socioeconomic status, but I see very little data on caste and gender. Gender has been reduced largely to sex in this case. For example, like we illustrated with the previous discussion, roles that parents play, the diverse roles they play, etc., has not so much been examined. So would you agree with me in saying that the inequity aspect has been less developed in your results, and there is quite some scope to further examine that aspect? What are your thoughts on this?
Yes, it's indeed a very good question. I think this is our limitation we have done in terms of the caste-based data. So inequity data related to inequity. So these are the dimensions may need require more sophisticated methodologies for future research.
Correct. I agree with you. You might require more social science qualitative methods to examine some of these. So I appreciate that. Maybe I don't have more time left.
That's
So
right. We have to
thank you so
move
much,
on.
Prafulla.
Thank you for your questions and the answers. Then the opposition will be continued by Professor Luc Smits. He was a member of the assessment committee and he's a professor in clinical epidemiology and risk-based care.
Thank you, Rector, dear candidate. I would like to echo the congratulations of the previous opponents on the publication of your thesis. It was hard labor, but now the delivery is there. My questions concern chapter 7, your study on maternal depressive symptoms and developmental delay of the offspring. I'm a methodologist, so I'm interested in how things are measured. So I would like to ask a few questions about the assessment, the measurement of depression, and also a couple of questions, if there's still time, about the measurement of the outcome. So let's start with the assessment of depression. You write in that chapter that depression was during pregnancy was measured after 14 weeks of pregnancy, but women could be included up to 32nd week of pregnancy. So depression may have been measured in some women during the second trimester of pregnancy, and then other women in the third trimester. And we know that the risk of depressive symptoms varies during pregnancy. It may be twice as high during the third trimester as compared to the second trimester. So if a woman was included during the second trimester, she may not have displayed depressive symptoms and may be classified as not having depression. But if the same woman had been included in the third trimester, she may have developed depression in the meantime. Could you maybe reflect on how this may have affected your results?
Thank you, dear opponent. Thank you for your question. In the Maastricht birth cohort, we attempted to recording the psychosocial factors, including depressive symptoms, once during pregnancy. So majority of the women who had participated in our cohort were in the second trimester. And it was open to us whether we have recruited the women who had a gestational age between 14 to 32 weeks of pregnancy. So I think we had only one-time assessment of depressive symptoms we had carried out, and we followed them further before delivery and for the OGTT investigation test, and at the time of birth, in order to record the birth estimations of the growth parameters of the child.
Okay, so you say that was I know that you wrote that down. You only measured it once during pregnancy and once after pregnancy. But important is what you are saying. It's that most women were included during the second trimester of pregnancy, so the noise is not as high as I feared. Okay, then let's go on to the measurement of postpartum depression. My question would be a bit similar. It was measured also once, but within 72 hours after delivery. But we know that more than half of all women experienced baby blues during these first few days after delivery. And many of them will feel perfectly well after 1 week after their delivery. So I'm concerned that there was a large amount of misclassification at stake here. So I would be curious, first of all, what was the prevalence of postpartum depressive symptoms in your sample? And a second one is if you believe that that is a correct reflection of what you really want to measure, namely genuine cases of postpartum depressive symptoms that may have influenced the child's development.
Thank you, dear opponent. I think it's a very, indeed, it's a very good question. So we agreed your concerns. So we followed up the delivered women after delivery, and we also attempted to assess their depressive symptoms at 14 weeks. But having said the postpartum blue, it does impact the behavior of the postpartum mothers. But this is very difficult for the first-time mothers having this postpartum blue, and with the few additional responsibilities like taking care of a baby and adjusting to the timings of the baby, so sacrificing her sleep, I think it is even more complex to her. So just rather than neglecting this psychosocial reassurance, at least from the family members, need to be advocated here. So this is my point to make out here. This has to be considered. So the severity may vary with respect to the postpartum blue severity. So
yeah, but aren't you worried that you might have classified many women as having depressive symptoms while they only had this bout of postpartum blues, which more than half of the women have, and which perfectly resolves in most of the women?
I agree with your question, but actually, in order to see with my findings with the existing studies, so it also supported even the range of prevalence I have got is very lesser than which has already reported in India. So in order to say the prevalence varies across geographical setting. So in the urban settings, this is a prevalence, and it may be lesser in the rural setting. And with respect to the facility, also it differs. In the referral hospital, it may be higher the prevalence, and rather than the primary healthcare setting. This is what we have done at the majority of the public primary healthcare facilities.
Okay, let's stop for now. I'm content for now with your answers, and I would like to hand back the floor to the rector. Thank you.
Thank you. We'll move on. The opposition will be continued by Dr. Sundarnach. He is an additional professor of psychiatry and consultant in perinatal psychiatry service and adult psychiatry in Bangalore. Professor Sundarnach.
Thank you, Professor Christine. Okay, first and foremost, Prafulla, big, congratulations to you for all your hard work, and it has reflected. As Mr. Prashant was telling that, it was reflected in your publications in, leading journals, right? So, doing a community study, it's not so easy in India, right? So there are a lot of challenges. So while doing, while going into the community, going into the antenatal clinic, so what are your experiences of difficulties, while interacting with the either the pregnant or the postpartum mothers? What difficulties you experienced?
Thank you, dear opponent. Thank you for this question. It is indeed a very interesting question. So this is what I wanted to reflect here. So when we started our cohort, while started enrolling the pregnant women in the facility, the most of the focus of the pregnant women is on related to taking care and as soon as possible meet the gynecologist and complete the test and go off to leave the place facility and go off to the home. So in order to convince the pregnant women who are waiting to take care at the meet the gynecologist was very bit quite hectic for us. I think for the women, I think majority we have taken two attempts to convince her, and later we had gone back to the family members, and later we have convinced them, and once they agreed, we had started enrolling them in the cohort. So convincing and making consent, obtaining consent, even from the pregnant women and from the family is quite challenging task here.
So, continuing to, your response, see, the psychosocial aspects or overall what we call as a mental health aspect of the pregnant woman. No, it's like a Pandora box. Okay, so it's not, it's not so easy, to explore psychosocial stress or psychosocial factors or the mental health aspect. So, do you have any say experiences? Once you start opening about the mental health aspect, then it's like a Pandora box. You don't know what is that new thing is coming, right? Say in any research, you need to interact with the human beings, whether it's a pregnant or postpartum, you need to interact. Apart from the questions which are in the APDS, you also ask other questions, which opens their mental health. Any experience of pregnant woman you would like to share while you are collecting the data collection?
Yeah, this is very good question. I want to recollect one of the incidents when I was interacting with pregnant women, especially during pregnancy. So most of the women, as like I told you before, so they are accompanying along with the in-laws. So majority the mother-in-laws. So while recruitment, we found that whenever this privacy is required for assessing this APDS and the social support. So when we started assessing the women's depressive symptoms, I think when we took her to the private room, I think during the interview itself, she broke out and she was weeping like anything, and she was sharing her all the personal experiences, whatever which is going on at her in-laws' house. Majority, I think, the relationship they had with the in-laws and partners, it is a main reason for them for causing these depressive symptoms. And the extramarital relationship of the husband, it is also one of the major findings. So we observed while interacting with the women.
No, it's quite interesting, Prafulla. Okay, now having done so much of work, having published so much of your work. So what is that message you want to give to the policymakers? Right. So initially you told that the mental health assessments or psychosocial assessment are not part of routine antenatal care in India. Right. So what is the message you would like to give it to the policymakers? From the findings what you have.
Thank you for this question and the kind words. So actually, with respect to the mortality reduction, India has achieved tremendously. So this was only quite possible because we had a strict agenda. So with respect to the sustainable developmental goals, and so thereby we were given much more importance to the nutrition aspect. Thereby we were able to tackle the mortality and morbidity. But so now having this mental health issues are coming up more. So this has to be, mental health has to be in the agenda somewhere. And if we're doing this, I think we can track the symptoms and the treatment and how this may in turn lead to the overall improved maternal mental health, especially in the perinatal women.
Okay, thank you, Prafulla. Thank you for your response and all the best.
There's time for a short question.
For
Or
me,
do you want to stop? Yes.
okay. It may be a kind of an, rather than question to Prafulla, kind of a question to, kind of a comments. So what, Prafulla has looked at the Doha, that is the developmental origin of health and diseases, Doha hypothesis by Professor David Barker. Somewhere down the line, the psychosocial stress which can influence the environment, the psychosocial environment, the maternal psychosocial stress can influence the growth and development of the child. That's what Dr. Prafulla has tried to show. And even though the kind of a cortisol is considered to be a stress hormone, there are many other factors which are playing a role here. So it's just a comment to Prafulla. No, we have not exactly able to pinpoint what is the why the psychosocial stress, how the psychosocial stress has an influence on the growth and development of the fetus or the child. It's just a comment. Thank you. Over to Professor Christine.
Yes. Okay, thank you. And then the opposition will be continued by Professor Edgar van Meel. He's a professor in youth, food and health at Maastricht University.
Thank you, Madam Pro-Rector. And dear candidates, well, as the last opponent in a row, for me also your congratulations with this fine manuscript, and I also like to congratulate your team of promoters. I would like to go with you to chapter 6, maternal depressiveness and infant growth outcomes. It's a very interesting chapter, of course, because you assess depressive symptoms among the delivered women within 48 hours after delivery. And you use the Edinburgh postnatal depression scale, which is a validated scale. Our colleague Luke Smits already assessed or addressed the timing, but the scale itself is valid, of course. And you compare your results to measurements of adiposity and stunting. And in the introduction, you refer to a few references, like reference 17. And I looked them up, and I saw that the first one that accounts children at the age of 3, so not age of 1 or younger, but the age of 3, and they use BMI Z-scores. And we know after the age of 2, you can use BMI Z-scores, and underneath it's not possible because they're not validated for this. And then the other reference is about younger children, 6 months, so that comes more close to your population, but they only use weight gain. But can you comment why you use these two references to sort of support your thoughts here?
Yeah, thank you, dear esteemed opponent. Thank you for this question. In public facility, we do not have advanced measurements such as PPOD or DEXA. We use measures that can be implemented in hospital settings. So with respect to this, we had assessed simple techniques which reflects adiposity measurement in children under 2 years. So we got trained by the St. John's research team in order to measure this anticometry biomarkers and followed up rigorous measures like SOPs we have been followed up so while in measuring the skin fold thickness and others. So this is also, I think, with reference to the previous studies that has been happened in local settings of Karnataka, they had also followed the same criteria with respect to the references and citation.
Okay, okay, understand. And I fully agree. It's not possible to do DEXA scans or some kinds of these sophisticated measurements. But instead you use skin folds indeed, and waist and hip or chest circumferences, and you decided above percentile 90, then we define adiposity. And then you refer again to other references, and again you used references in older children. If reference 34 is about 12 to 14 years old, and 35 is about 10 to 70 years old. And indeed, it's very difficult to do skin folds in these very young children of 1 year of age. We normally use weight for height or weight for age even, according to WHO standards. But you decided to do skin folds. Can you explain why you use these measurements? Why it's difficult to refer?
Thank you for this question. Actually, I think we did not feel like difficult to assess the skin fold thickness in children. So we got from the beginning, we got trained under the St. John's team. So with the hands-on experience of holding the pinch from a child and assessing for the in the various time points. So I think we did not feel as a team, we had been certified once in 6 months and we had been followed at the SOP throughout the year.
Mm-hmm. So you're saying that these measurements are indeed validated in the Indian population?
Yes.
Okay. Well, that's reassuring, because I was a bit worried here that you draw your conclusions on measurements. Because you also don't give any information about the weight for length or weight for height in these children. Do you have these information? Do you, because it is measured. You wrote down that it's measured, but why aren't you showing these results?
Yes, it's indeed a very good question. We do have this data. Have showed the weight for length on the infants, but I have not explored in 1 year of old. I think in the future I can go back and explore more on the weight for length. Thank you.
Okay. Thanks. Another question is regarding the chapter before, chapter 5. It's regarding cortisol measurements. Fortunately, you already explained in your presentation they were the blood was drawn in the morning because we have this diurnal rhythm with cortisol. But you also state that it's only a subgroup of women that had this blood drawn on cortisol. Can you tell me a little bit more about how this selection was made, which women were used for cortisol measurements, and can you more describe this subgroup in order to better understand and interpret the results you relate from this?
Thank you for this question. I think it's a very interesting question. So we have decided to go by subgroup analysis, considering the cost associated with the diagnostic test. So based on the reference estimate for the prevalence of flow by weight, we had coming to the conclusion of the final sample size to be achieved, which is 230. So this we have been collected by the help of random number tables. So we have, after the completion, those who had delivered successfully with the live birth children. So we had selected those only 230 women randomly and proceeded with the serum sample assessment. So we stored samples during pregnancy, and later once they completed the delivery, then we had gone back to the biorepository and selected these 230 randomly generated samples and given for the laboratory for the estimation.
Okay, I understand now how it worked, but how did you make the selection then? Or can you tell us a little bit more which women are these higher income women, or are these lower income, or are they a sort of a random selection among the total group?
We did not select any women based on the socioeconomic status or the depressive symptoms or other. We randomly picked out of these 3,000 women, 230 were randomly picked and proceeded with the examination.
Okay, so it's a randomly picked way. Okay. I see it's 11 o'clock. Can I proceed with another question? Because then I would like to go back to chapter 6 because it's still one question left for me, and hopefully you can help me with the answer. You just explained about the adiposity, but the other factor in this chapter is the stunting, of course. And you found stunting in this in association with depression and stunting. And to me, it's intriguing how it's possible to have adiposity on one hand and stunting at the other hand, because as you know, children grow on calories in the first 2 years. So if you have an expose or an excess in calories, which causes adiposity, you would also expect a normal growth, at least not a stunted growth. Can you explain how this would work pathophysiologically?
Yeah, so thank you for this question. The mechanism behind stunting is more probably the behavioral mechanism.
Who asked?
Okay, thank you. Prafulla Shriyan, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in the meeting. Okay, we are all there. Prafulla Shriyan, the degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor van Schaik is authorized to confer upon this academic distinction in accordance with the Dutch university custom. I invite your supervisor to now take the floor. Professor Onno van Schaik.
Thank you so much, Prorector. Dear Prafulla, I'm first going to ask you a question. Do you promise to work in accordance with the principles of scientific integrity at all times? To be careful and honest, transparent, independent, and responsible. What is your answer on this question?
I promise.
Now, by the authority vested in us by law, and in conformity with the decision of the committee here present online, I hereby confer upon you, Prafulla Shriyan, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree of certificate, signed by the rector, the secretary, and its supervisor, affixed by the official seal of the university, shown now by the beadle.
Okay. Professor Giridhara, you can start a laudatio of Dr. Prafulla now.
Thank you, Prorector, dear opponents, Prafulla, her family members, esteemed colleagues, and guests. It's my distinct pleasure to give this personal reflection and to stand before you as we celebrate the remarkable achievement of Prafulla in towards the award of PhD. Not just for the academic excellence, Prafulla is known by her team members and the participants of Maastricht research team for her kindness and also her tenacity. She has traveled in terms of a long journey and transformed herself by facing numerous challenges, be it geographical, social, and personal, and transcended to what we see her today as an awardee of the PhD. And this should inspire several aspiring professionals to practice with tenacity and also to ensure to stay committed to the path whenever they're pursuing research in low and middle income countries. In Maastricht cohort, we are grateful for Prafulla's efforts in establishing the standard operating procedures for the lab and all her hard work in making sure that the lab's done really well. Plus, he also conducted several air pollution studies in slums in some of the most difficult areas. And now we are grateful for her in CTRIH, where she's working in the tribal area. So all this only proves that she is arduous, she takes up challenges, and she follows it through to see the results. Several of her colleagues have congratulated her and commented on this journey. Some have said she's courageous. All of them respect really high. They are inspired by her team skills, and also they are inspired by her how she tackles the personal challenges. She's a great mother, a great wife, apart from being a great colleague. But most importantly, what strikes is her humility in learning, also in influencing, and using this as a strength and overcoming all the weaknesses. I am really happy to see her transformation. But that I feel is just the beginning. I feel she'll continue to accomplish several aspects in future, and her journey will provide inspiration to all of us and await for those next chapters in her life. Congratulations, and I'm happy to call you Dr. Prafulla.
Thank you, sir.
Okay, dear Dr. Prafulla, also on behalf of the Maastricht University, I congratulate you with the degree that you have acquired. I wish you a nice day and a very nice and fruitful career, further career. And
Thank
I
you.
hope you can have a small party with your family today and friends, of course. So now I hereby declare the official part of this ceremony ended. We can stay for a while in the meeting, and we are Dr. Prafulla, the supervisors and the degree committee, to congratulate you. Who wants to congratulate Prafulla with some personal words?
Shall I